the word psychoanalysis, as you correctly said, refers to multiple different things. The three major things that it refers to is it's a body of knowledge. It's a rich, and complex literature that has developed for well over a century. It is a range of different treatments that are informed by this body of knowledge. Right? Treatments plural, not one. And it's a certain sensibility. It's a certain way of thinking about mind and behavior.
Hello, this is Robinson Earhart here with the introduction to Robinson's podcast, number 132. And I just recently got my wisdom teeth removed, and the recovery is not going well. It is very painful. I don't think I'm just a baby, but that could be part of it. But again, I don't think that's what it is. So I am loaded up on painkillers right now, and my mouth only hurts slightly. But maybe I'm already failing this. I was going to say I'm going to be more laconic in this introduction than usual. But anyway, this episode, which I just finished recording, is with Jonathan Shedler, who's a clinical professor in the Department of Psychiatry and Behavioral Sciences at the University of California, San Francisco. And he's also a faculty member at the San Francisco Center for Psychoanalysis. So, Jonathan, if you couldn't tell so far, is a psychologist and psychotherapist. And I've done a couple of these sorts of episodes lately. By these sorts of episodes, I mean those focused on mental health. And I have in mind Anna Lemke and David Spiegel, past guests in this area. And there are a few reasons for this. So one, the mind and its problems are incredibly compelling, even independent of my own mind's myriad problems. And then second, building on that, like with many people, I've had depression and anxiety and all of these things. And I like to have as good an understanding I can of how those in and outside of the medical establishment approach and see mental illnesses, because it helps me understand my own mind, where I fit into the world, and then also how people I know might be dealing with their problems or experiencing them. And then third, I suppose there's a bit of a PSA component in that mental health and therapy are still, I think, very wrongfully stigmatized. And I'm not deluding myself into thinking that these podcast episodes are really changing that. But the more these issues are discussed, by me to a small extent and by others, the more accepted as mainstream they become. So with all that being said, in this episode, Jonathan and I discuss contemporary psychodynamic therapy, which I emphasize as distinct from psychoanalysis, especially as Freud envisaged it 100 years ago. And we talk about the caricatures of contemporary practice, how it differs from its portrayal a little bit in popular culture, and how psychodynamic therapy compares to other forms of therapeutic modalities. This is all far from exhaustive, but there will be more to come. And in the description, you'll find links to Jonathan's website and his Twitter. And now, without any further ado, other than please leave comments, likes, and don't leave a subscribe, but subscribe. I hope you enjoy this conversation as much as I enjoyed having it with Jonathan. I've had a couple of conversations on the show already that have touched on Freud, notably with Paul Bloom of Yale and Toronto, if you know the name. And you're, of course, more than aware that contemporary psychology has no room for Freud, and that psychoanalysis is pretty similarly maligned by the medical establishment. So while I know that, say, 60 years ago, psychoanalytic theory was still dominant in psychiatry, I'm under the impression that when you did your training, it was already out of fashion. So how was it then that you, I guess, bucked this trend and ended up spending your career to this point studying and then practicing psychoanalysis and its offshoots?
Well, so let's set the record straight right off the bat, because you framed the question in a way that I think is very representative of how lots of people, including educated people, think, and that's very unhelpful. You said psychoanalysis, but you started off by asking me about Freud. And let me ask you a question. If I were, say, an astrophysicist, would you be asking me, would you be equating the field of astrophysics with Copernicus? And would you be asking me, how did I become interested in Copernicus? Or if I were, a biologist or evolutionary biologist, would you ask me to define myself as a Darwinian and conflate the name of a single individual, who was the founding father of the profession for sure, with the current contemporary profession itself? I mean, I don't think you would. So I don't, I think it's a common misconception. Freud wrote literally in the horse and buggy era. It was more than a century ago. We've had a century of evolution and development of psychoanalytic or psychodynamic thought since then. And I mean, there have been sea changes in theory, thinking, practical technique, how we work with people. And I just think we don't really facilitate anybody's understanding when we speak about psychoanalysis as if it were synonymous with, the writings of Freud himself, any more than, contemporary biology is synonymous with the writings of Darwin, even though he was the central founding figure of evolutionary biology. So we've got to separate the subject. Now let me answer the question you meant to ask. I was in a kind of a transitional phase. I'm one of very few people in the field who has been both an active empirical researcher and a practicing clinician. It's very rare. The field is bifurcated. It's not like there's such a thing as a psychologist. You get a common, foundation of knowledge, and then you branch off from there. We use the same word, psychologist, but most of the people who are doing research in psychology have never seen a patient in their lives, and they've never been trained to see a patient in their lives. Most of the people who are clinical practitioners have no connection to the world of research. So, my own personal background was unusual. I really straddled both disciplines, and I was kind of on the cusp. I mean, at the time when I was trained, psychodynamic perspectives were going out of favor, but it hadn't become the situation that it is now, where it's just routinely caricatured, stereotyped, misrepresented, turned into a foil and a straw man for every other therapy or treatment tradition to sort of, set up as a foil to mock in order to aggrandize their own approach. I mean, the fact of the matter is the core insights of psychoanalysis are timely, and the other therapy approaches that, have largely defined themselves in opposition to psychoanalysis, it's kind of funny, over time have been increasingly incorporating these core psychoanalytic understandings, usually under a different name, right? Old wine in a new bottle. And in some cases, I don't know if it's, I don't know whether it's ignorance or disingenuousness or some combination of that. But in some cases, representing the ideas as brand new discoveries of their specific therapy tradition or model, when in fact, they're reinventing the wheel and, and addressing things that clinical practitioners, psychotherapists, psychodynamic or psychoanalytic therapists have literally been dealing with for generations. So there's a certain amount of disinformation in the field.
Well, I'll start by responding to your first point, which is that, no, I framed the question in that way because I entirely agree with you. And in that same sense, that is how the contemporary psychologist or medical establishment would see the situation. They would equate Freud with psychoanalysis today.
Yeah, and they would be wrong
Right.
to do so.
That's what.
But I appreciate that you gave me the opportunity to address it.
Yeah, well, that's exactly what I wanted to get to at the outset. So the key terminology that we need to establish to set ourselves up is elaborating on this distinction between, I think, psychoanalysis on the one hand, and then psychodynamic therapy and the other. But these terms themselves are even misleading because psychoanalysis, as you said, is far from the same thing today that it was 100 years ago.
Yeah, it's not your great grandfather's psychoanalysis, any more than any branch of science or medicine, is done and practiced today the way it was in 1900. Mm-hmm. So and obviously it's not just you. I mean, the perspective that you're giving voice to is widespread, and people get introduced to it in their introductory psychology texts. And in college courses in Psych 101, they read these textbooks that are across the board, written by people, by and large, who are not clinicians at all. They don't know anything about clinical work, period, let alone psychodynamic work. And, from the get-go, they'll have a chapter on psychoanalysis, and they'll talk about, what Freud wrote not even mature Freud, like Freud circa 1905. And they'll get even that wrong. But they'll leave students with the impression, that their misrepresentations of Freud's ideas are synonymous with what psychodynamic psychotherapy is today. And the funny thing is, so much of what Freud actually said and wrote has just been just incorporated into our ways of thinking in the culture. We take it, we take it for granted. It's just part of our shared consensual understanding about, different things about human psychology, mental life, behavior, that we don't even recognize as originating with Freud. So what's happened is people have taken some of the most, inaccessible ideas of his and off-putting ideas, say, penis envy, to take an example. That's Freud. And all of the things, I mean, that is so peripheral to the body of his work. So many of the things that he actually wrote about, we just take for granted. The idea that, that our experiences, our earliest attachments in our early formative years affects us throughout our lifespan. The idea that trauma, like emotional trauma, is a real thing and is the cause of psychological and physical symptoms. Those are Freud's ideas. The idea that you could provide treatment to somebody suffering from mental or emotional distress just by talking to them. Right? That originates with Freud. The idea that that psychotherapy is a regular, ongoing, continuing meeting between a clinician and a patient or a client. That was a Freudian idea, right? So, what we've done in the culture is we've taken the most inaccessible things, identified it with Freud, taken all of the, things that are more accessible and kind of treated them as, shared common property with no origin, as if we always knew it. So, I just sort of hate equating contemporary practice with the history. But if we're going to talk history, textbooks, common sources of information in the field of psychology and psychiatry also get the history wrong. Mm-hmm. So maybe you'd like to talk about what it's really about as we understand
Well,
it.
that's what I wanted to get to, but just adding to what you've said, it's not even so simple as just a Freud contemporary psychoanalysis dichotomy, because Freud is far from the only historically significant psychoanalyst. I mean, there's Jung and Lacan, and then psychoanalysis, beyond just a treatment modality, it's become a mode of philosophy or cultural criticism or interpreting Marx. And then even with regard to contemporary clinicians, different analysts use different methods. Then the same is true for psychotherapy.
Yeah, and the contemporary theorists that we certainly that I think about, rely on, read, that most inform my work, I will tell you, are people that you and 99.9% of your listeners have never even heard of. I mean, the people who are in textbooks are not, are not representative of the profession today. And that's because the textbooks are written by people who are not clinical practitioners and are certainly not psychodynamic practitioners.
Mm-hmm. So I think we're on the same page. And the point that I'm just making is that when psychotherapy or psychoanalysis are attacked, it's usually with this caricature in mind. And there are many different caricatures that can be drawn upon. So
absolutely.
Granted all of this, then, how do you think of psychoanalysis on the one hand as it's practiced today? What does it consist in? And then psychodynamic therapy.
Okay, so these are kind of wiggle words. I mean, the word Freud used was psychoanalysis. Actually, the word he used was German, Psychoanalyse, which was kind of a hyphenation of two words that don't go together, which is psyche, the psyche of mythology, psyche, the soul, the spirit, the breath, right? And this very sciencey word, analysis, and he deliberately combined the words in a way that created a paradox. So, we're dealing with the human soul, but we're trying to approach it in a systematic, rigorous way. So, the word psychodynamic, actually, the history of it, the word came into usage, prominent usage, after World War II. I think it was first introduced in the early 1950s at a conference on medical education, psychiatric education, where directors of psychiatry residency training programs were meeting to consider and discuss the curriculum in psychiatry. And then there were people who wanted very much for psychoanalytic ideas to be incorporated into psychiatry training, which in fact is what happened then. Right? Psychiatry was largely dominated at that time by psychoanalytic perspectives. But the concern was that psychiatry training directors would be alarmed by this concept of psychoanalysis, that even then it would conjure images of, I don't know, cigar smoke filled European, consulting rooms. The word was a bit of a ruse to get psychoanalytic thinking into the curriculum without alarming people. It's come to be used, though. So let me back up. The word psychoanalysis, as you correctly said, refers to multiple different things. The three major things that it refers to is it's a body of knowledge. It's a rich, and complex literature that has developed for, well over a century. It is a range of different treatments that are informed by this body of knowledge. Right? Treatments plural, not one. And it's a certain sensibility. It's a certain way of thinking about mind and behavior that really could apply across any kind of intervention. I mean, so when I was an attending doctor in a psychiatry outpatient department, I would supervise psychiatry residents, and some of them were dealing primarily with medication. Right? What does this have to do with psychoanalytic or psychodynamic anything? Well, it has everything to do with it. It's not the treatment you offer. It's not what pill you prescribe or the dosage. It's how you understand the person to whom you're providing the treatment. Right? So a body of knowledge, a range of treatments based on this knowledge, and a certain way of thinking about and understanding people. No, the word psychoanalysis proper sort of evolved to refer to one specific kind of treatment, which is typically done, back when, 4 or 5 days a week. Often the patient lay on a couch. This doesn't happen very much anymore. Most of the people who still get that kind of treatment are people who are trainees becoming psychoanalysts themselves. So psychoanalysis proper was, a 4 to 5 day week treatment. Psychodynamic therapy was treatments based on psychoanalytic principles that were typically, once a week or maybe twice a week, and the patient would typically sit in a chair, not on a couch. So you could think of psychodynamic as I personally, I don't even like to make the distinction. These are all psychoanalytic therapies, but psychodynamic is a bit of a broader tent.
First, I want to ask, so when you say that psychoanalysis is a range of different treatments, are you referring, when you say it's a range of different treatments, are you referring to the original psychoanalysis proper and the psychodynamic therapies, or are you saying that there are multiple different treatments of psychoanalysis? Say, there are different a different treatment might correspond to a different condition that is being treated.
Well, every treatment is, no two treatments are alike because it's very individual. But there are different schools and models and approaches within the big psychoanalytic tent. And I personally think it's been harmful to the profession to identify psychoanalysis with one very particular kind of treatment, that involves very frequent meetings on the couch. That really, that's a very small percentage of psychoanalytically informed treatments. And that's a pretty rarefied kind of thing. And, there's a movement, and I'm part of the movement, to use the word psychoanalysis more broadly to refer to, the range of treatments that are informed by this understanding and this sensibility, rather than reserving it basically for a guild that practices one very specific and very, sort of old and traditional approach to treatment.
Okay. And then one last thing I wanted to clarify is you said that there are very few people on the couch these days. It's mainly trainees. But do you see...
Not exclusively, but yeah, it's not common.
Do you see any feature of psychoanalysis or psychodynamic therapies that cleaves the two at the joints, so to speak? Or is it really just a continuum between the couch practice and then the various psychodynamic therapies?
I think it's a continuum, and I can tell you the continuum. So if you think of it like two poles, defining two ends of the continuum. On one end of the continuum are interventions aimed at understanding and insight, interventions aimed at coming to know ourselves more deeply and more fully, which is really the essence of what these treatments are about. At the other end of the treatment, other end of the continuum, are treatments aimed at providing support, stabilization, shoring somebody up who's functioning, ego functions, or as we now say, executive functions, may be failing. And the fact of the matter is, every treatment includes interventions along the entire spectrum of that continuum. It's really a matter of the blend and where a particular patient and doctor or therapist are at a particular moment in time. So I think trying to make a categorical distinction to me, seems arbitrary and not especially helpful.
And then beyond, so there are these three components that you identify to psychoanalysis. There's the body of knowledge, the family of treatments, and then the way or sensibility of understanding and treating the mind. So
a way of thinking about ourselves as human beings.
And how do you explain just what this way of thinking about ourselves is that is so intrinsic to psychoanalysis?
Two things stand out for me. I mean, one is the fundamental recognition of psychoanalysis that in some very important ways, we're not masters of our own house. What I mean by that is, by virtue of being human, none of us fully know our own hearts and minds, right? There are levels of awareness, levels of consciousness, right? There's far more to who we are than what meets the eye on the surface of things. And the things that we don't know about ourselves, that we're not aware of, can cause real problems for us in life. Right? So the idea is that by coming to know ourselves more fully and more deeply, we become more whole. I can talk more about what I mean by more whole, but for the moment, we become more whole. We gain the ability to free ourselves from having to live out the same, sort of repetitive patterns that we're all stuck in to a greater or lesser extent. Right? So the goal of the work, contrary to caricatures and stereotypes, the goal of the work isn't to dwell in the past. The goal of the work is to be able to live more fully and freely in the present. So that's one aspect, right? The recognition that we're not of one mind, we're of many minds about pretty much everything that's important. And we can know ourselves more fully through a particular kind of process of exploration. The second is what we call the second part of the sort of sensibility or attitude with which we approach the work is there's a real humility about it. And the humility is that we just reject the assumption that anyone can know what's right for somebody else. Right? What is a satisfying and meaningful way of living for that person? Right? Hopefully, we can find satisfactory answers for ourselves. We don't have those answers for somebody else. So there's a term in psychoanalysis, it's called neutrality. It's wildly misunderstood. What it really means is utmost respect for the other person's, for the patient's autonomy and agency and self-determination. We're not in the business of trying to tell them what's right for them, give them answers, tell them how to live. We're in the business of helping them to know themselves more fully and deeply so that they can find, their own answers to questions about what's right for them.
I hadn't heard of this concept of neutrality before, and it's quite fascinating. And I imagine that it can be quite difficult as a clinician to get past your own preconceptions with certain patients, or for some given clinician to get past their preconceptions.
Yeah, well, that's part of the training and part of the work that we have to do. But I mean, it's actually, it's not that hard to explain. Suppose you have a dilemma. Suppose you have a romantic interest, somebody that you want to pursue a romantic relationship with. And part of you is drawn to that person, and part of you is wary and hesitant. It's a very, very common, human situation. But, imagine most of us have experienced something like that. And a sort of a layperson's perspective on what would be helpful to that person would be, oh, well, let's understand your situation. I'm going to give you advice, right? I'm going to figure out what's right for you, right? And, and then encourage you to do one thing or the other. But another way to look at it is the person is in conflict. The person is of two minds about what they feel, what they want, what they think is right for them. And so we could say there's two or more parts of the self that are, operating at cross purposes or in conflict with one another. And Neutrality means, technically, specifically, I'm not going to take sides with respect to the internal conflict. I'm on the side of deeper understanding. So what I'm actually on the side of is, can we make space to really hear deeply and fully from both sides of the conflict? Right? Usually people come in and they're kind of identified with one side. There are two minds about it, but they're aware of, they identify with one set of feelings or desires. The opposite, or the contradictory set of desires, is kind of operating, from the shadows. And we get to hear a lot about one side of the conflict and not so much about the other. It kind of goes underground, except it's still exerting its influence. What we say is, let's hear from all of the different parts of you. Let's bring everything out of the shadows. We're on the side, not of this solution or that solution. We're on the side of understanding all of the different parts and pieces and facets of who we are. And out of that understanding comes the possibility of resolving those inner contradictions, resolving those conflicts, finding a way to make choices and decisions, with a sense of sort of harmony, where all the different parts and pieces of us are working in concert rather than at cross purposes. And they're working in concert because they've all come within our awareness and our understanding. Right? So neutrality is not taking sides with respect to the person's internal conflicts, but being on the side of understanding and insight.
I'd like to return to the first of the two components of the sensibilities that you mentioned, and it's that this acceptance that we don't fully know our own minds, we're of more minds than one, and part of the goal is becoming more whole. And so I understand that in Freudian psychoanalysis, one of the goals, one of the ways of becoming more whole is, quote unquote, making the unconscious conscious. And I'm sure there are many, but at least two ways that this happens in psychoanalysis is through the fundamental rule, which is free association. Somehow bits of the unconscious are supposed to come out when one free associates. And then the other thing that comes to mind is transference. So relationships that one has had, or relationship patterns that one has in their life, come out in the dynamics of the relationship between the analysand and the analyst. And through the analysis of these two things, and I'm not using analysis in a technical sense here, the analysand and the analyst come to know the unconscious of the analysand better, and it becomes conscious. And what I'm wondering is if these two components of Freudian psychoanalysis are also very important to contemporary psychodynamic therapy.
Yeah, but I'm impressed. You've done your homework, but I would say it. I would say it differently. First of all, I although the term is used, relatively commonly, it's to me, it's just not helpful to speak out the unconscious. That makes it sound like it's a thing, or a place, or it's not. We operate on many levels of consciousness simultaneously all the time. There's consciousness is a continuum, not a category, right? With respect to the things that in principle could come into awareness, could become conscious, you could think about like a rheostat or a dimmer switch rather than on-off switch. It's not the unconscious, the conscious. It's levels of awareness. Unconscious is, it's as trivial and mundane in day-to-day life as just, a thought, an idea, a feeling comes up and it just slips by. We don't take a special notice of it, or focusing on something else, right? Sort of taking the spotlight of our attention and putting it on something else, in a way that takes our attention away from away from the other thing, or downplaying it, or minimizing it, or disavowing it in some way. So I think the unconscious, just there's things we are more and less aware of, and there are some things that we kind of have a vested interest in not paying too close attention to, because they're threatening, or they're painful in some way. So many comments about the unconscious. Let's talk about what you identified correctly as transference, but let me put it in my own words. We, by virtue of being human, we acquire certain patterns, relational patterns, through our earliest formative relationships, and for that matter, through all of our relationships subsequently. But they start in our earliest attachments. You could think of them as sort of internal templates about who we are and who other people are in relationship with us. We are born into relationship, so we internalize these templates, or we could call them working models of how the world works, how relationships work, that really the maps that we navigate by as we navigate our way through our lives. And those maps are formed in very important ways, early on. So it's not pathological. It's not a disorder. It's just a fact of human nature that we acquire certain patterns of ways of being and ways of relating to other people fairly early on, right? Lenses through which we look at self and others. And we bring those lenses and those patterns with us into every relationship we enter. And it's not a matter of choice. It just is. It's how we're constructed. And the patterns are often invisible to us. It's like water to a fish. If you've never in your entire life experienced not water, I mean, how would you have a concept of water? When you're going to tell the fish, of course there's water, you're swimming in it. And the fish would be like, it's the water we swim in. It's largely invisible to us. Psychotherapy or psychoanalysis is also a relationship. And when we enter that relationship, we bring those lenses and those patterns with us. And what we do, if we're skillful clinicians, skillful psychotherapists, is we arrange things in such a way. We stack the deck by the way we structure the therapy, so that those lenses that the person brings, or those relational patterns that the person brings, kind of stand out in high relief in the therapy relationship. And that's what makes it possible to recognize, discuss, understand, and hopefully rework those patterns, so the person isn't doomed to spend the rest of their life repeating the same painful or self-defeating patterns over and over again on an endless loop. A colleague of mine says, and I like the way he put it, right? So just to tie your two questions together, the things that we are not aware of, that are the patterns of how we function and how we relate in the world, those things become manifest in the relationship with the therapist or the analyst. And that's what we mean by transference, right? The therapist is seen and experienced through the lenses of the person's sort of patterns and templates and formative relationships, right? So we become aware of what is outside of awareness as it becomes manifested and recognized in the treatment relationship itself.
Thank you for clarifying what I said. You totally answered my question about the transference, but maybe I missed it if you answered my first question, which was if there is something roughly comparable to the fundamental rule that's at work in all of the psychodynamic therapies, that there is that there's an encouragement to free associate.
Yes. So it's called the basic rule, but Again, these are sort of terms of art that therapists, use to talk to one another. That's not what we say to our patients or our clients. Right? So the basic rule is simply that, we invite the person to speak as openly and freely as they can about anything and everything that occurs to them, that comes up during the session, without editing or censoring themselves, without deciding beforehand whether it's important or relevant. Right? If you think it, feel it, right? It could be thoughts, feelings, memories, bodily sensations, mental images, the words of a song that pop into our head. Right? I mean, anything that we notice that occurs to us is sort of fair game, and we ask the person to try to speak as openly as they can. Now, the first thing that a trainee discovers so if you ask people, and we always ask, right? This has to be the therapy relationship has to be something that both people enter voluntarily. It has to be mutually desired and agreed to. So we don't tell the person this is how you're going to do it, but we invite them. We explain the process and why. And would you be willing to give it a try and proceed that way? In my entire career, I've never once had somebody say like, no, I don't want to do that. And usually I say, yeah, not so fast. Because, it's easy. It sounds easy. It's actually extraordinarily difficult. And what we find when students, trainees start, learning this kind of therapy is this kind of free association is actually impossible. It's a hypothetical ideal, right? Right? The person cannot do it. And much of the work that we do is really aimed at, noticing the things that get in the way. Right? So one theorist wrote that one of the goals of this kind of treatment is to have the freedom to go anywhere in our mind that we want. And people come into treatment and they don't have that freedom. And by noticing the things that get in the way, that stop thinking and feeling, that obstruct it, that deflect it, and it's not random. It's very consistent. There's sort of some always there are certain core themes that kind of structure what gets included and what gets excluded, what's easier to talk about, what's difficult to talk about. I mean, we start to notice the structure. We start to notice where and how and why things get excluded, bypassed, attenuated, minimized, dismissed. So the process of the treatment is one where the person becomes increasingly able to experience and describe their experience more openly and freely, in a way that flows. And that's part of what I mean when I say that a goal is to become more whole and more free. More whole in the sense that all of the different parts of ourselves, all of the different aspects, the ways we're not of one mind but of many minds, there's space to hear from all of the parts, or at least to hear from a lot more of them and a lot more clearly than when we started. So by coming to recognize and understand the things that get in the way and working through them, the person gains access to a greater range of their experience. That's what I mean by becoming more whole. But that also creates the option of being able to do things differently. Right? So one thing that happens, we're talking about things that happen unconsciously or automatically, or let's just say without conscious attention and awareness. The way we experience a lot of our lives is something happens. Let's say it's point A, and point A leads to point B, and it's inevitable. It's not a matter of choice. It's not a matter of volition. When this happens, that happens. That's the way it is. And one of the things we do is we try to slow things down, because in fact, between point A and point B, there's a lot going on. Thoughts, feelings, memories, experiences, sensations, images, and things that were previously, automatic and sort of outside the realm of choice and volition. When we slow things down, we actually start to realize that between point A and point B are a lot of different options and choices. So things that used to happen in a very, sort of automatic, repetitive way slowly become matters of choice. Life choices expand. Life options expand. So when I say, the goal is to live more freely, that's part of what I mean. Right? And the funny thing is, people like to contrast, or I don't know, contemporary experimental psychology is, good and psychoanalysis is bad, or neuroscience is good and psychoanalysis. Every one of the things that I'm talking about is actually, confirmed by, contemporary laboratory experimental psychology research and by neuroscience research. So for example, you had Dan Kahneman on your podcast a while ago, right? Nobel Prize winner, right? Prize-winning psychologist for his work on experimental cognitive psychology and decision making. And he coined the term. He talks about system 1 and system 2, two ways of thinking and two ways of thinking and processing information and responding to the world. And one system is consciously monitored. It's within our awareness, and it's slower, and it's more systematic, and it's deliberate. And the other system happens. He doesn't say unconscious, because that's a bad word. He says implicit. It happens implicitly, which is what an experimental psychologist says implicit. They mean not conscious. It happens quickly, implicitly, automatically. That was the title of his best-selling book, Thinking Fast and Slow. You talk about system 1 and system 2. I actually used to know Danny Kahneman way back when. I don't know if he'd remember me. We'd have occasional conversations about this, but I don't know to what extent he knows it. But Freud he talked about primary and secondary process. Secondary process being what's consciously, what we're consciously aware of, and sort of follows the rules of conscious logic and conscious thought. And primary process, which is not typically in our awareness and functions according to a completely different set of rules. And we're talking about exactly the same thing, but there's sure as hell some overlap here. And the same with, neuroscience. I mean, the parts of the brain, the prefrontal cortex that, the parts of the brain that we associate with, conscious thought, reasoning, logic. I mean, these are evolutionary and developmentally latecomers. These are add-ons to the brain. The rest of the brain was already there. And when I say evolution, I mean both with respect to the evolution of the species and the neurodevelopment of the individual. I mean, we think consciousness is king. And that's what I meant when I said, the fundamental insight is we're not masters of our own house. Consciousness is the tip of the iceberg, and it's a latecomer to the party.
I'm not sure if you know Mark Solms. You've probably heard of him.
I do know him.
He was just on the show recently, and we spoke a lot about consciousness, but he's well known for finding what I'll refer to as the psychoanalytic neural correlates. That's a lot of what his research is about. But granted that we've already said that you see it you see psychoanalysis and psychotherapy as psychodynamic therapy as a continuum, I have found clarifying their connections and their connections to Freudian psychoanalysis very, very helpful. And returning to this sensibility of mind, us being of multiple minds, and a desire of making them or becoming more whole, I realized that I neglected to mention one very important feature of Freudian psychoanalysis, and that's the interpretation of dreams, which is another way of getting at the unconscious. Though, as you said, the unconscious is not just one thing. But this is also one of the aspects of psychoanalysis that is most attacked, I think, as being unfalsifiable, not scientific. And I'm wondering if...
What's the it?
Sorry?
What is the it that's unfalsifiable? You just named an activity.
Right.
What's falsifiable or
if
not
you claim that
falsifiable is a specific conclusion or claim about something that's true. So what's the it that's not falsifiable?
An analyst hears an analysand's dream and then draws some connection saying, this is what your dream represents is going on in your unconscious.
It doesn't work. Yeah. Okay. It doesn't work that way.
Yeah.
It's a misunderstanding. So, Freud did refer to dreams as the royal road to the unconscious. And for Freud, it was the gateway into understanding something about the structure of how the mind is organized. This is not, I don't think this is far from a universal view among contemporary psychoanalysts. All mental life, all mental phenomena are of interest, are of equal interest, are invited into the treatment. Dreams are one manifestation of our mental life. They're not at the center of anything. They're not at the royal road of anything. I mean, Freud found through dreams a method of understanding, of sort of moving beyond the surface of experience. That method applies to everything. We don't cordon off dreams and say, this is a special activity. I'm going to interpret your dreams. First of all, we don't interpret. And second of all, we tell the patient, talk openly about whatever comes to mind. And when we do that, and the patient's able to do that, their thoughts just move freely, between, things in the present, things in the recent past, things in the distant past, reality, fantasy, daydreams, night dreams. And it's all a free flow of thought. And when there's something that we want to understand, we invite the patient, to attend to it. And, I'll say to you in technical terms, follow their associations. We say to the patient, what comes to mind? What does that bring up for you? Where does your thought go? Where do your thoughts go from there? What occurs to you next? We're tracing out associative networks, and we're not interpreting the patient's experience. We're creating the opportunity for the patient themselves, right, to delve more deeply into their experience and begin to make some connections and see and know and feel some things that are not on the surface of things. So we don't interpret. It's not like you listen to a dream and you say, it means this, right? If we did that, then it would be something that in fact was falsifiable, right? We'd collect dreams. We'd collect the interpretations. At the very least, could different independent psychoanalysts come up with the same interpretation? Could we plausibly link those interpretations to anything, sort of concrete, observable, measurable in the person's life? If that's what the work was, then we're talking about something that you could talk about in terms of falsifiability. We're not doing that. We're creating an opportunity for the person to further explore their mind. And the old word, going all the way back to Freud, was interpretation, which I don't think in contemporary times is a very helpful word. We don't make interpretations. Nobody has access to somebody else's internal subjective experience. All we can do is offer hypotheses, possibilities. Could it be that this is happening? Could it be that? Is it possible that the reason you feel this way here is because it comes a little too close to this other experience, right? That just came readily to mind, and in talking about the first experience, and it's a mutual reciprocal process, right? Well, we offer an idea or a hypothesis not to be right, but to put something on the table that the patient may not have been able to consider themselves, and now it's on the table for both of us to consider together. The patient is the arbiter of their experience, right? Not us. We just create the conditions to, allow them to come to know their experience more fully. So this whole idea of, I don't know how we're going to change it. I mean, Freud's book, or at least the English translation of it, was The Interpretation of Dreams. I mean, it's in the language, it's in the culture, but that's not really how it's kind of the wrong metaphor. We're not interpreting things.
So just to clarify for my own understanding then, the presumption in the psychodynamic context would be that if a patient, say, has a dream and recounts it in the session, this is somehow connected to their thinking and the web that is their mind, but the nature of this connection isn't something that a therapist would assert can be concretely ascertained, but rather it can be used as something like a springboard to entertain possibilities.
We can use it as a springboard for further exploration. And when I say we, I mean the therapist and the patient together. It's a mutual, collaborative, cooperative endeavor, right? It's work for two minds. Neither one of them could do this work alone, right? The two of us together can arrive at, a increasingly truer understandings of the patient's experience. Yeah. So there's a web of associations, and we know something, right? Now we're getting into the sort of brass tacks of how we work and think psychoanalytically. But you could think of the mind as a vast associative network, like the internet, like the web, right? Like things are hyperlinked. Everything is, sort of, linked and cross-linked with everything else, right? So if you jump on the web, interesting things happen, right? You can, I don't know, you can get on a page about, Taylor Swift's most recent concert, and click a link and that takes you somewhere else, and you click a link and that takes you somewhere else. And the next thing you know, 4 or 5 clicks away, now you're on a page about Shakespearean sonnets, right? Right? Everything is linked. Everything is interconnected. On the web, the links are based on content generally. In the life of the mind, the links are based on affect, like emotional connection. Things are linked that contain or evoke the same feelings. That's why every traumatic experience you've ever had in your life is associatively linked with every other traumatic experience you've ever had in your life. Right? We follow the links, right? And we respond based on our own unique, sort of infinitely complex, pattern of, interconnected links or interconnected associations. I mean, that ultimately correspond to neurological networks, but they're not static. They're not fixed. They're plastic. They're changing, right? They can, right? New networks can be created. New associative links can be created. New experiences can be created. Everything is, sort of continually dynamically in flux. What we're trying to do is recognize how we respond to certain situations in the present, really in light of things that happened in another time and another place. Because we're responding, based on past experience, we're not necessarily recognizing the choices and the options, the possibilities that actually exist in the present. That's what a lot of this work is about.
Well, I have really loved getting down to brass tacks and getting into some of the specifics. But I mean, I guess this means it's probably not the right time to switch gears. But I think one of the most important things we can do today is talk about the efficacy of psychotherapy, because that's one of the main things that is challenged by what I will just refer to as the establishment. And I know you've researched this significantly. And
well, that's my field, so let's go there.
Yeah. And just to start off, this isn't a deep question, but are there a few named schools, so to speak, of psychodynamic therapy that are most practiced or otherwise well known that might be singled out in the literature, or do therapists just advertise, I am a psychodynamic therapist?
I know. I mean, we've got some problems here. This idea of, schools and these internecine disputes between theoretical models. I mean, I don't personally don't have a lot of interest in that. I'm interested in kind of the bedrock of sound psychoanalytic or psychodynamic practice. So I'm not an Ian. I don't insert, or I don't add a suffix, Ian to my name. I think and work psychodynamically. There are about 5 major currents of psychoanalytic theory. And the people I respect, right? Every theory, every newer theory, came about to address some limitations in the previous dominant theory. It's kind of like Kuhnian paradigms and paradigm shifts. And then at some point got grandiose and made claims to be a total universal theory of everything. That's not really how it works to me. Different theories put our focus on different aspects of mental life, right? They highlight certain things for our understanding. And which of those things is most relevant or salient to a particular patient depends on that patient. So I don't start with a theory and say, this is what I am. I'm an Ian. Right? I won't go into names. Everyone who comes to me gets this. And say, how do I understand this particular person? Where's the action? Where's, to use a sort of crude expression, but we have limited time. The person has an entire life ahead of them. Right? I mean, the goal is to do something in this work that is going to make a meaningful difference in their life, or to shift the life trajectory that they're on in a way that hopefully makes things easier, better, more satisfying for them. And we have limited time to do it. So, crude economic metaphor, but where's the bang for the buck? What do I need to home in on? And that's where the theories become relevant, right? Because the theories address things that are going on, that are relevant to everyone, but the action is going to be somewhere for one particular person. So do you want me to sort of walk through
Sure.
So one theory is what we call classical psychoanalysis, which is about drive and conflict. And it's morphed into what we call in the field ego psychology. But the idea is there are drives or impulses, desires, and there is something in us, goes back to being of two minds about things, that opposes them. And that we end up, working across purposes with ourselves, right? And so that puts the focus on internal contradiction and conflict, and that's one lens to look through, right? There's drives or desires, and there's defenses against them, and what happens out of that sort of dynamic, that sort of dynamic tension, and that's where the word dynamic came from in psychodynamics. Another lens is we have internal representations of the world, specifically the relational world, internal working representations of self and others and relationships. That's called object relations. There's historical reasons why we say objects rather than people or relationships. But objects mean, for all intents and purposes for our discussion, objects mean people. How is our internal world populated? Who's in there? Who are we responding to? Who are we in relation to them? Right? So, drive theory or ego psychology is one major current in psychoanalytic thought. Object relations, right? How is our internal world populated, and how do we live out, right, those internalized relationships? Object relations is another current. Self-psychology is concerned with how do we maintain a coherent and vital sense of self? What do we have to do to maintain a sense of coherence and a sense of, sort of positive regard, positive sense of ourselves? How do we do that? To what extent do we have internal capacities, to manage to feel all right about who we are as we move through the world? To what extent are we reliant or dependent on other people to sort of provide that function for us? So that's the domain of self-psychology. And then with the rise of this, really sort of paralleled the rise of postmodernism in other areas of thought. We have relational psychoanalysis, which says, you can't look at a person. They call it a one-person psychology. You can't look at a person in a vacuum. It's not a mind in isolation. We are born into a sort of matrix of relationships, literally from the instant of birth. So how are we, two people or many people, how are we mutually shaping and co-creating one another's experience? Right? And they call that a two-person psychology. Right. So the original, Freud's original psychoanalysis was, relatively speaking, a one-person psychology, was concerned with intrapsychic processes within the mind of one person. A two-person perspective shifts the lens to what we could say interpsychic processes. What happens when we have people in interaction with each other? Well, so I'm not any of these things. I'm in all of these things. It's like a person comes into my office. I don't know them. I don't know what's wrong. I don't know why they're there. I invite them to tell me, and I start listening. What am I hearing? What are the themes? What are the patterns? Because we don't listen randomly. We listen for patterns. We listen for repetitions of the same theme across different areas of the person's life, right? Across different times in their life, across different domains of their life. We listen for convergence. Are we hearing similar themes or patterns converging in different areas of their life? Right? There's a way that we listen, right, to kind of home in on what is this person's central psychological preoccupations that are causing difficulties for them that could be amenable to, it could be amenable to developing, to shifting, to evolving through the work of the therapy.
That was incredibly helpful. And I think it sets us up perfectly for what I wanted to ask next, which is how these 5 theories, but we'll just refer to it generally, this family, as psychodynamic therapies, how they differ from what you've referred to in your writing as instruction manual therapies.
Yeah, well, that's easy to answer.
CBT and prolonged exposure.
Well, I think what I call good therapy has a lot in common, regardless of the brand name of that the therapist thinks they're doing. But there's been a movement in the last, say, 20 or so years in psychology and psychiatry, and it doesn't mean, it's a buzzword. It's marketing. It doesn't mean what people think it means. And the word is evidence-based therapy. People think evidence-based means what it says. Like, there's evidence here. Like, there is evidence that this is helpful. There's evidence that this is more helpful than other approaches. That's not what it means. It's not true. It's a misconception. What evidence-based therapy really is, de facto, is it's a code word for very, very brief therapies, typically 8 or 12 sessions that are conducted in a standardized way, literally by following an instruction manual. So, if you've been talking to people about research methods, right? There's the thing that a particular research study is aimed at finding out. But before that happens, before you collect any data at all, the researchers are bringing a world of assumptions with them. And those assumptions are not scientifically tested. They are assumed a priori. And if the assumptions are false, the findings that rest on them are likewise, uninterpretable or untrustworthy. So they say we're going to study evidence-based therapy. It means it has to demonstrate some benefit in a randomized control trial. That's really the definition. But then they smuggle in a shit ton of assumptions that are not scientifically derived and that I would argue in some cases are flagrantly false. One assumption is that the way you conduct therapy is in a standardized, uniform way according to an instruction manual. There is not a shred of evidence to support that leads to better treatment or better outcomes. That's an assumption they bring. The other assumption they bring is it's not a finding of the research. It's an a priori assumption. We decide before we collect any data that this treatment is going to be an 8-session treatment or a 12-session treatment or very, occasionally, at the extreme end, because it's pretty difficult to write a manual for, for anything beyond a pretty limited, finite number of sessions. 16 sessions at the far extreme. Well, that assumption's false. We know a few things. We know a few things from more than a century of clinical experience. We know a few things from naturalistic, empirical, rigorous naturalistic research. How long does psychotherapy really take? So, and the answer to that is that people experience some if they're having acute symptoms, usually they experience some remission of those acute symptoms very quickly within the first few weeks. It doesn't matter what the brand of therapy is, right? I mean, just the fact that they're doing something and taking active agency to try to do something to help themselves is already, an intervention, right? So everybody gets some immediate relief generally. But for actual psychological change to take place, right, it takes about 6 months not before the person is well, it's before something starts to shift in what they call, a clinically significant way. Right? 6 months for meaningful change to begin, about a year or 2 years for the person to actually, really get what they want from the treatment. We know this from a convergence of lots of different kinds of studies, right? So if evidence-based therapy researchers were serious about doing things based on evidence, those would be the starting parameters. We're going to study therapies of six months to 2 year durations. That would be our starting assumption. Well, what they do is they study therapies typically of 8-session duration. Meaningful therapy hasn't even begun. So there's a certain amount of smoke and mirrors about this. And then the smoke and mirrors get worse. They don't ask the question, or at least let me say, they don't emphasize the question. Do people get well? How many people get well? What percentage of people get well? Or at least meaningfully better? How much better? And do they stay better? They don't ask those questions. They ask a completely different question that nobody in the entire world should give a damn about except an academic researcher, because the question is an artificial question that has nothing to do with reality. The question the research studies that evidence-based therapy is asking is, I have two groups. I have a group that gets the treatment I'm invested in, and I get a group that gets no treatment or a fake treatment that's not intended to be helpful. And the question is, can I show that there's a statistically significant difference on average between this group and that group? Is there a difference between the groups? Why should anybody care? It's not an interesting question. It's not a scientifically interesting question. It's not a scientifically relevant question. It's not a clinically relevant question. I don't care if this group is a little bit different from that group. The question that patients and therapists must be concerned with is, are people getting meaningfully better, and are they staying better? That's the only relevant question. And there's this magician sleight of hand that goes on. We pretend that we're addressing the important question. Are people getting better? We say, yes, this is an evidence-based treatment. This is the gold standard. This is scientifically proven. But we're not paying any attention to that question. We're only concerned about, is there a statistically significant difference between the groups? So here's where I come in. The people who are sort of championing this cause of evidence-based therapy, they keep pointing to these studies. They say, look, scientifically proven, scientifically proven. Well, the very same studies that they are pointing to promote what they call, quote unquote, evidence-based therapy, those studies demonstrate scientifically that the treatments are failing the overwhelming majority of people, right? But they deflect from that and they shift the conversation back to statistical significance. Let me put some hard numbers around that. The most researched condition, you've got to slice things and study people with uniform symptoms, at least for research purposes, right? The most studied condition is depression, major depressive disorder. Hundreds of studies on manualized, brief, so-called evidence-based therapy showing that people who get one of these therapies in the immediate short term, on the day the treatment ends, are doing a little better with respect to depression symptoms and nothing else than people who got no treatment or no treatment that was meant to help. Right? They keep pointing to these studies and saying evidence, science, research. Right? Here's what the studies actually show. 7 out of 10. I want to repeat that. 7 out of 10 of the people who get these brief instruction manual therapies do not improve at all or else relapse very quickly. So from my point of view, as a practicing psychotherapist, as a patient, I've been a patient. Any good, serious psychotherapist has been a patient. From my point of view, you've got a treatment that even by the most narrow possible narrow sort of artificially defined outcome criteria, even by your own researchers' outcome criteria, is failing the overwhelming majority of the people who get the treatment. Now you go out in public and you start saying evidence-based, 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 and people hear that word and they think it means, if I get this treatment, the overwhelming likelihood is that I'll get well, or at least I'll get meaningfully better. And the science actually shows the exact opposite, right? So there's kind of this is a smoke and mirrors thing that's going on. There's a gap between what the research actually shows and the narrative or the buzz about what research supposedly shows. And very few people understand this. I mean, most people can't critically read and evaluate the primary sources. Right? I mean, they've got to rely on so-called experts to tell them what the studies, show. And the experts say things like, evidence-based, which is not a scientific word. It doesn't have any scientifically defined meaning. Gold standard, proven. These are marketing words, not science words. Right? And we're selling a bill of goods to the public and to clinicians also, who think science shows that these treatments get people well. They get some, sort of small minority of people who get them well. They don't get most people well. And there's a lot of reasons why, but one really crucial reason why is because the entire literature is absolutely at odds with what we know about realistic durations of therapy, realistic parameters. It takes 6 months before meaningful psychological change begins. Right? These therapies are over before they started. So, yeah. And so as far as what research really shows, it's not true that any other therapy has been found to be more effective, across the board than psychodynamic therapy. In fact, if you look at the major modalities of therapy, legitimate bona fide therapies, I'm not talking about, fringe things, mainstream legitimate forms of psychotherapy. In fact, nobody has actually ever consistently shown that any one of these therapies is better or more effective than any other of these therapies. So that's possibly the most replicated finding in all of psychology research. It's called the dodo bird verdict. After the dodo bird in Alice in Wonderland, there's a race, and I think it's the dodo bird who says all have won and all must receive prizes. You cannot empirically show differences. And there's reasons for that. And I think it's because the outcome measures are the wrong measures and the treatments are too short. But that's another matter. Right? The truth is, the dodo bird verdict is well replicated. Using our current, typical current research methods, we cannot show differences between different forms of legitimate therapies. And in that sort of empirical literature and that sort of empirical context to bring in the word evidence-based and apply it to certain therapies and exclude other therapies, right, just doesn't actually fit, right? Fit the scientific findings. So, 20 years of my research in 2 sentences. We have plenty of randomized control trials of psychodynamic therapy, more than 300 at current count. The finding is absolutely consistent, right, compared to the typical control groups that are used in therapy outcome research. Right, the therapies are consistently effective. They are at least as effective as the therapies that are promoted, branded, advertised as evidence-based. Right? So psychodynamic therapy has, in fact, been empirically shown to be effective. It's part one. Part two is, if you really look under the hood of the research on evidence-based therapies, you find so-called evidence-based therapies. Like I said, you find that most people, most of the time, are not getting well. So there's like the truth about what's going on in psychotherapy research, and there's the narrative and the buzz about what's being shown.
Well, there are many things that I would like to say, many doors that have been opened. But one brief thing before I ask a final question is that I imagine, just to add a theoretical gloss to what you've said, that one reason for the lesser efficacy of the instruction manual therapies when compared to the psychodynamic therapies is that the instruction manual therapies are geared toward symptom relief. And they're neglecting to use this. When I hear this word, I kind of roll my eyes, but the much more holistic approach of the psychodynamic therapies, which is
you don't need to roll your eyes. There's empirical research on this. You can ask patients, what do you want out of therapy? And if they're suffering from acute symptoms, like most commonly depression or anxiety, of course they want relief from those symptoms. But that's actually way down the list of what they want. People come in because they're having problems in relationships, because they can't get close to people, because they don't experience intimacy, because they don't find meaning and fulfillment in their work and their daily pursuits, because they have problems with authority, because they get in their own way. They have inhibitions. They trip over their own feet. They do things, right? They do things that get in their own way of having what they want. If you ask people what they really want from therapy, and this has been done empirically, right? You get answers like that. And in the mix, if they're having acute symptoms that happen to, fit in a category of a DSM diagnosis, yeah, that's in the mix too. But it's not even at the top of the list. It's further down the list of what they want. So, there's so many mismatches between what psychotherapy is really about and what real patients in the real world and real therapists want from psychotherapy and what researchers are studying. It's like they're operating in a parallel universe under, different rules, but there's only one universe, right? So that's one of the assumptions, right? I said before they collect any data, they make all these assumptions. Well, one assumption is that the world divides in any sensible way according to DSM diagnostic categories. No, it doesn't. People don't fit neatly into these categories. There's no such thing as depression by itself. Right? Depression is not the cause. To me, depression is not a cause of anything. Depression is an effect. You become depressed because of, and by the time you get to a therapist, because of the difficulties woven into the fabric of your life and who you are. You don't come down with depression like you come down with a case of influenza, right? Depression is an outcome that tells us that there's something else going on that's causing difficulties. Right? And that's what the real psychotherapy deals with, is the something else. But psychotherapy researchers say, no, depression is the thing. I'm going to look through at the world through this lens that filters everything out. Everything about the person, everything that a legitimate psychotherapist would be focusing on, everything that the patient themselves might say they want from psychotherapy. I'm going to filter all that out and, until there's this like tiny little, glint of light, which is your scores on, on a depression symptom scale. This little fragment can come through the lens of what I'm looking for. And I'm going to declare that to be the whole universe. And then I'm not going to do therapy long enough to find out what really becomes of you. I'm not going to look at any broader outcomes beyond that. I'm not going to follow you after the therapy is over for any meaningful amount of time to find out whether you actually got any lasting benefits. And on the occasions when people do that, and the answer is no, there don't seem to be much lasting benefits, I'm not going to trumpet that to the world and advertise that. I'm going to play that down. That gets published somewhere, buried in an obscure journal somewhere, right? When the original findings come out and they show a positive effect, we tell the world. When we do the follow-up, a year later, and we find out that the treatment group is basically indistinguishable from the control group, right? No one hears about that finding.
Well, Jonathan, there are so many things that I want to get to that we didn't have time to. Personality types and syndromes are just one of those things. So we'll have to do a part 2. But thank you so much for doing this with me. It was really a pleasure.
My pleasure. It was fun to talk about it.
Hold on. If you haven't subscribed, liked, commented, or reviewed, that would be so helpful. And if you haven't yet, you could also follow me on Twitter and Instagram at Robinson Earhart.